So are we ready for today's session, beta? Okay, perfect. So keep asking me, keep mentioning wherever you need another explanation or anything during the session. Okay. So let me take you through the first question, bache. Let me take you through the first question. The first question is, a poorly controlled diabetic patient presents with recent onset red dot like floaters. Which of the following tests can help in confirming the diagnosis in this case? So, friends, for all the questions, always read the question statement carefully. Pick up the key points or the key words which are going to help you clinch the diagnosis. Try to see which option fits the best for the given question. So, what are your key points in this question? Go step by step. What is the nature of the patient? What kind of patient they are describing here? A poorly controlled diabetic patient, beta. So it's a diabetic patient. This patient is now presenting with floaters, but these floaters, they have a specific characteristic. They are sudden, recent onset, and red dot like. Okay, so what kind of the floaters will appear red dot likes? Most likely it has to be some kind of bleeding. Okay, so reddish floaters, they are because of the hemorrhage. A diabetic person can present with a vitreous hemorrhage or hemorrhage in the vitreous cavity as a complication of, as all of you know, proliferative diabetic retinopathy. So here what we are looking at as is that this patient has a vitreous hemorrhage. Vitreous hemorrhage is a complication of proliferative diabetic retinopathy. Now, to make a diagnosis of proliferative diabetic retinopathy, what do you need to see in the fundus, beta? What do we need to see in the fundus so that we confirm the diagnosis of proliferative diabetic retinopathy? So, once again, all of you know that you have to see new vessels in the fundus. Either these new vessels, they can be neovascularization on the disc, or they can be neovascularization elsewhere. Now, coming to the choices here, which of the test will help us to find the new vessels? As almost each one of you have already told me the right answer. So, is it indirect ophthalmoscopy? No. Indirect ophthalmoscopy gives you a less magnified view of the retina. So it's mostly for the peripheral retina. Okay. Optical coherence tomography? No. Optical coherence tomography is examination of macular area only. And mostly it tells us about the macular diseases. So if it is a macular edema due to diabetes, we may be able to confirm it with the help of optical coherence tomography. Fundus fluorescent angiography. So, fundus fluorescent angiography is the investigation which is going to help us pick up the new vessels on the retina, because here the dye will outline the vasculature of the retina, and if there are abnormal vessels, we will be seeing it on fundus fluorescent angiography, or what is called as FFA. The choice D, electroretinogram, ERG, it's an electrophysiological test of retina. So ERG is an investigation of choice for retinite diseases like retinitis pigmentosa. It has no role to pick up the new vessels. Okay, so this is the explanation that why the FFA is the right answer here. Now, why I put this question, because I want you to learn that what will be all seen when we do fundus fluorescent angiography in this test, beta. Okay, now this is important. Recently the questions they have been asked based upon the FFA findings in diabetic retinopathy in other exams. So it will be a good idea that we also revise what will be seeing on FFA in a diabetic patient who has proliferative diabetic retinopathy. Okay? So, my dear friends, you will get this PDF after the class from this platform only. From the it will be posted at our channel. Okay? So, don't worry about the PDF. So, let's concentrate on this fundus fluorescent angiography picture representing the patient which we just discussed. So in FFA, the dye goes into the vessels, and when the fundus camera takes the picture, the blood vessels or the vascular elements, they appear whitish in color. Okay, so if I mark it here, beta, so this is like normal looking blood vessel. Okay, these white dots which you are seeing here, the white dots, we call them as hyperfluorescent dots. They are your microaneurysms. Okay, these white, all white dots are your microaneurysms, beta. Fine. And here you are seeing in these area the dye which is leaking from the blood vessels, the dye which is leaking from the blood vessels. So these are the areas of neovascularization. These are the areas of neovascularization, because new blood vessels, they are abnormal, they are not strong walled, so for that reason they will leak the dye. So that is how FFA will confirm proliferative diabetic retinopathy. To let you know, the areas like this, beta, which are appearing blackish or hypofluorescent, they are the areas of capillary non-perfusion. We know in diabetic retinopathy there is ischemia, so there will be certain areas where capillary are occluded, so those areas, they will appear as capillary non-perfusion. Okay, so this covers all the findings which you see on FFA in a diabetic patient in cases of diabetic retinopathy. Okay, so let me summarize that for you, beta. So you are able to see microaneurysms which appear as hyperfluorescent dots. Hyperfluorescent dots. Okay, you are seeing new vessels or neovascularizations which appears as leaking blood vessels. Okay, you are also seeing areas of non-perfusion where capillary block is there. Okay, so this is what is all you are seeing here. ठीक है बेटा, any question related to proliferative diabetic retinopathy, any question related to FA findings in the proliferative diabetic retinopathy, I'm sure you will be able to attempt. And this also makes you revise that in a diabetic patient you can get a sudden onset floaters, decreased vision because of the vitreous hemorrhage, which is a complication of PDR. ठीक है बेटा? So, got all the information related to this question. Now we move on to next question. Now we move on to next question here. Okay. So here you go. Now, this is a clinical case scenario. Let's go through it. A lady who wears a hypermetropic glasses since childhood presents to emergency with headache, vomiting, severe pain in the left eye. Let's again go step by step, go one by one with the important key points. It's a female patient. Okay, it's a female patient who wears hypermetropic glasses since childhood. So she is a hypermetrope. Hypermetropia means a type of refractive error in which the axial length of the eye is less than the average. So it's a smaller eyeball. Okay, patient is presenting to emergency, so it's an acute condition. And what are the symptoms? She is having headache, she is having vomiting, she is having severe pain in the left eye. So severe pain, headache, vomiting, acutely presenting. Patient is unable to open the eye, means there is a photophobia, and eye is stony, hard to touch. Okay, so every word is important, beta. Stony, hard to touch eye means the pressure is so high that our eye is feeling like as hard as a stone. What are the examination findings? The eye examination shows mid-dilated pupil. Pupil is not reacting to light and it is stuck in a mid-dilated position. Corneal edema. Cornea is hazy. Shallow interior chamber. Anterior chamber has become shallow. What will be the immediate treatment of this patient? So this question has two parts. First of all, based upon the clinical case scenario, you have to make the diagnosis. And then once you have made the diagnosis, you have to choose the right treatment option for this patient. Okay, so very nice. I'm so happy. Most of you have already given me the right answer here. So, what is your diagnosis, beta? What is your diagnosis? Let me first clarify the diagnosis for all of you. A patient, a female patient, lady, hypermetropia. So, both of these are your risk factors for narrow angles, beta. Being a female, being a hypermetropic, smaller eyeball, these are risk factors for narrow angles. Okay, now this patient, when it is presenting with acute pupil block, the eye pressure becomes extremely high due to acute angle closure. So that kind of thing, as you always know, will occur whenever pupil dilates. So pupil can dilate if a patient goes to a dim light condition, remains there for a long period of time. For example, watching movie in a movie theater, or when the patient is is scared, anxious, the sympathetic stimulation will lead to pupil dilation. Or if you put a cycloplegic drug in these kind of patients, for example, you put atropine in these patients will go into pupil block. So when there is pupil block, the intraocular pressure becomes very, very high. It goes up to 50, 60, 70 millimeter of mercury. That is why the eye is stony, hard to touch. And because of this very, very high intraocular pressure, patient has symptoms like severe headache, vomiting. So these patients, they are very, very uncomfortable. And these are the examination or slit lamp findings. The eye is congested, the cornea is hazy because of the corneal edema. Very high intraocular pressure will lead to corneal edema. You are noticing here the pupil is in mid dilated condition because of the ischemia of the sphincter pupillae muscle, iris muscle. It can be oval, it becomes ovalish in shape, it does not react to the light. And if you see here the depth of the interior chamber, there is hardly any depth seen here on the slit lamp examination because of the shallow interior chamber. So this question is an example for you to identify acute angle closure glaucoma or acute congestive glaucoma based upon the clinical case. Now coming to the treatment. So what is the immediate treatment, beta? What is our priority? है ना, सबसे पहले क्या करना है? The priority is to reduce the intraocular pressure rapidly. You want, because if the pressure remains so high, the optic nerve is going to get damaged very quickly. So you want to bring the pressure to the normal levels very rapidly. And one drug which can cause rapid lowering of the intraocular pressure is your mannitol. So you will be giving intravenous mannitol to these patients. So that is the first thing. Then the second thing is you want to reverse the attack of the angle closure. The attack of the angle closure happened due to what? Because of the pupil dilation. So you want to reverse this pupil block. So you want to constrict the pupil. And which is the drug which will cause constriction of pupil? Pilocarpine. Okay. So that is why you will first give intravenous mannitol, and then you will start intensive pilocarpine eye drops so that pupil becomes smaller in size, the attack is reversed, and then later on you may need to add other anti-glaucoma drugs. And as a definitive measure later on, what you need to do, you will do peripheral iridectomy to prevent the future attacks. Okay, beta? Right? So here in the options, coming to the options here, the choice A is your answer, intravenous mannitol and pilocarpine eye drops. Of course, you are not going to give atropine. Atropine is going to make it worse. Here there is no role of analgesics. The pain is not due to some inflammation. The pain is due to high intraocular pressure. Prostaglandin eye drops, they are not going to work here because pupil block will be reversed only by giving pilocarpine. So you might give other anti-glaucoma once the acute attack has settled. Okay, very good beta. So I hope that makes your concept clear about the diagnosis of acute congestive glaucoma, about management of acute congestive glaucoma, and then as I just mentioned, you will do peripheral iridotomy or laser iridotomy in both eyes. In both eyes of this patient later once attack is over. Okay, when this acute attack is over, you will do peripheral iridotomy. The reason is because the similar thing can happen in the other eye of the patient also. So an alternate way for the aqueous to flow will be done for both the eyes once the acute attack is over. Okay beta, all clear? Fine. Moving on to your next question here, bache. Moving on to your next question here. So again, a very important question based upon ocular trauma. Please expect one question related to ocular injuries. For the last few times, the question have been coming on chemical injury. You know that well. So there can be a question based upon foreign body. There can be question based upon mechanical trauma. So let's see an example of an ocular injury based question, beta. Read with me. A mechanic is brought to the eye emergency following injury to the eye while hammering a nail. So it is very important to understand what was the scenario or situation of the injury. ठीक है, किसको इंजरी हुआ है, कैसे इंजरी हुआ है, that kind of the information you have to get from the question. So it's a mechanic, so it's a person who deals with, like, mechanical work. Injury while working with a hammer and nail, so it is something metallic. So hammers, they have got that iron material which is used to put the force there. It's an iron nail, so the person is dealing with metallic structures or objects. So this is what has happened after the injury. So what do you see first of all here, beta? What do you see first of all here in this image? What you are seeing here is, there is, have a look beta, there is a corneal laceration and the iris tissue, the uveal tissue, is prolapsing through that laceration. So there is a corneal or a limbal laceration and the iris uveal tissue is prolapsing through this. So what is this type of the injury? This is a penetrating eye injury. This is a penetrating eye injury. Okay. Now, coming back to the question. The management of this case includes all of the following except. So what you should not be doing if such a case comes to you in the emergency. First, primary repair of the eye. So that should be done. Primary repair means that you will suture this laceration. Okay? Because you want a primary healing of the wound. So that should be done. MRI scan to rule out any intraocular foreign body. Now, intraocular foreign body can be present in this case, but what kind of intraocular foreign body we are expecting in this case, beta? When a person is working with a hammer or chisel or metal works, so we are suspecting a metallic foreign body. Now, when you are suspecting a metallic foreign body, MRI obviously is contraindicated. Okay, because that will displace the intraocular foreign body, causing more damage. So you will not go for MRI in these kind of cases. You can preferably, the best will be to do CT scan, or if available, you can do X-ray of the orbit, or you can do ultrasound B scan, but after the repair, not in the acute stage. because ultrasound B scan, the probe will put pressure on the eye. So the preferred investigation will be, or investigation of the choice in the cases where you suspect metallic foreign body, will be a CT scan beta, not MRI. MRI is absolutely contraindicated. Now coming to the rest of the question here beta. So obviously the right answer to the question here is choice B, as you told me. What else should be done? Defer intraocular pressure measurement. You don't want to press the eyeball to cause further damage. And you must explain risk of sympathetic ophthalmitis. You should keep in mind this is a penetrating eye trauma. If you see there is a uveal prolapse there, which is a risk factor for sympathetic ophthalmitis. So that is why these kind of patients, they should have immediate primary repair of their injury. Otherwise, they can develop sympathetic ophthalmitis. Okay? So dear friends, can you tell me what kind of inflammation is sympathetic ophthalmitis? What kind of inflammation is what kind of uveitis or inflammation you see in case of sympathetic ophthalmitis? Yes? So you will see bilateral granulomatous panuveitis. Okay? So just your revision of sympathetic ophthalmitis also. So sympathetic ophthalmitis, no, you will not see anterior uveitis beta. In sympathetic ophthalmitis, so my dear friend, this is a good time to know about sympathetic ophthalmitis also. It is a panuveitis beta. Let's revise here. It's a panuveitis involving all the layers of the uvea. Okay, it's a panuveitis. It will be seen in both eyes. So that will be a bilateral granulomatous panuveitis बच्चे. ठीक है? याद रखेंगे? Yes, very good. Okay, so it is a bilateral granulomatous panuveitis, my dear friends, which will be there both in the exciting eye as well as in the other eye. Perfect. ठीक है? Okay, so are we ready to move on to the next question, bache here? Let's move to the next question here. Again, a very, very important question, beta. Question based upon the visual pathway lesions or the visual defects from neuro-ophthalmology, highly expected in the exam. MRI in ophthalmology can be done for a lot of things, beta, especially for the intraocular malignancies. If you remember, for retinoblastoma, the investigation of the choice is MRI scan beta. Right? Dr. Sharma, the rosate cataract will not be seen in penetrating eye injury. The rosate cataract will be seen in blunt trauma. Okay? Right? Okay, so my dear friends, here this question needs a bit of reading. Let's not jump to the answer. Let's read the question because I'm getting mixed answers here. So let's read the question. Elderly patient. So it's an old patient who was admitted in the hospital for recent stroke, beta. Stroke. Now complains of loss of visual field on his right side. Now it is not right eye, the right-sided field loss. Okay? His central vision is normal. Now this is very, very important. The central area of the visual field is normal, means there is macula sparing. So this is what you need to pick up from here, bache. Okay? This is what you need to pick up from this question. The patient had stroke. There is right-sided vision loss, visual field loss, not the vision loss, right-sided visual field loss with central sparing, or you can say macula sparing, right? And they have even showed you the defect here, bache. आप यहाँ पे देखें, have a look at this figure here. So this part of the visual field is gone, the right half, but there is a macula sparing here, bache. Again, the right half of the visual field is gone here, but there is a macula sparing. So the name of this kind of visual field defect will be, you will call it as right-sided homonymous, right-sided homonymous hemianopia, okay, hemianopia, but central vision is normal with macula sparing. Okay, my dear friends, all clear here? You will call this defect as homonymous hemianopia, macula sparing on the right side of the visual field. Now, one thing you have to remember, beta, macula sparing visual field defects, they are feature of occipital cortex lesions और occipital lobe lesions. ठीक है, तो इसमें optic tract तो आप हटा ही दीजिए. If there is no macula sparing, then it will be optic tract lesion. But if it is a macula sparing, then it will be a lesion in the occipital lobe involving occipital cortex. Now, whether it is the lesion located on the right side or left side. Now, again, as we know, the homonymous hemianopias, they are always contralateral to the site of lesion. Okay. The second thing to remember here is homonymous hemianopias, they will always be contralateral. They will always be, bache, contralateral to the loss of field. Okay. So if loss of field is right sided, means if it is right sided homonymous hemianopia, then the lesion will be on the left side. Okay, beta, right? So what is your answer here? Right answer of this question is left occipital lobe lesion. Okay, so Dr. Ambika Sharma, when we talk about that which sided lesion it is, okay, take this visual field as your visual field. So this is your right eye, okay, this is your right eye, this is your left eye. For the visual pathway visual field lesions, we divide the visual field into two halves, right half, left half. So in this case, the right half of the right eye and the right half of the left eye. So this is the right half of the right eye. This is the right half of the left eye visual field. So the right half of both eye visual field are gone. So that is why we will call it as right-sided homonymous hemianopia. Okay, I hope I am clear for everyone. It is right-sided homonymous hemianopia, and when the homonymous hemianopia is right-sided, it means the lesion is on the left side. So your lesion is in the left occipital lobe. Okay, beta, all clear here, right? Okay. Now, friends, moving on to a quick recap of visual field defect based upon the site of lesion at different areas of visual pathway. Okay. So please have a quick revision with me here. So this image I have put for that. So once again, visual field in the right eye, in the left eye, and you can divide it into two halves. Okay. We also call it as temporal and the nasal half. Fine. Now, if the lesion is at location A, if the lesion is here at A, that is in the area of the optic nerve, that will cause visual field loss only in one eye. Okay. So you will find a monoocular visual field loss. Clear, bacha? Right? If the lesion is at site B, which is the area of the central part of the optic chiasma, the central part of the optic chiasma contains nasal fibers from both the eyes. So it will be causing bitemporal hemianopia. Fine. And most of the lesions which involve the central part of the optic chiasma, they include pituitary tumors, beta, because the location is like that the pituitary tumors, they compress on the central part of the optic chiasma. So for example, pituitary adenoma, craniopharyngiomas, so they can cause bitemporal hemianopia. All right. Now, coming to the site C, if the lesion is in the optic tract. Now, optic tract is containing again the fibers from both the eyes, because the crossing of the fibers has occurred at optic chiasma. So, optic tract has nerve fibers from both eyes. So, optic tract lesion will be causing homonymous hemianopia. Homonymous hemianopia, as you see in the C here, but see, there is no macula sparing. No macula sparing. Okay? Now, if the lesion is in the D area, that is the area of the parietal lobe where the radiations they are going through the parietal lobe, that will cause an inferior quadrantic defect. So, it will be pi on the floor. Pi on the floor or inferior quadrantic defect when the lesion is in the parietal area. If the lesion is in the temporal lobe area, the radiations passing through the temporal lobe, that will be causing pi on the sky beta. Pi in the sky. That is a superior quadrantic defect. Okay. And if the lesion is in the occipital cortex area, as was our question, then it will be causing again homonymous hemianopia with macula sparing. Okay, why macula sparing? Because the area where occipital cortex is located has dual blood supply. It is supplied by both middle and posterior cerebral arteries. So most of the time in stroke or in thromboembolic conditions, the one circulation will be blocked, but the other will be then taking care of the perfusion in the area which is representing macula in the occipital cortex. Okay? So here you are getting macula sparing. Okay? So very easy to do these questions, bache. There is no kind of confusion. Just remember which area, which type of the defect. Okay? And important thing, as I told you, if the visual field loss is right sided, then the lesion will be on the left, because the lesion is contralateral to the field defect which we notice. Great. Fine. Moving on to the next question, bache. Moving on to the next question. A very simple question. I expect everyone to answer this question. Identify the lesion shown in the given image, bache. Identify the lesion shown in the given image. The clue given is patient gets the red eye with itching every summer season. So that is your clue here. Patient gets the red eye with itching every summer. Okay. So when there is itching, beta, when there is itching, think of an allergic condition. Okay. Though you get itching in trachoma also, but your first thing should be to think of an allergic condition. Okay. Then if it is related to seasonal variation, beta, then that also favors the allergic condition. So there is no decrease in vision given here. What they have given here is red eye with itching becoming worse in summer season. Okay, so what we are looking at over here, a type of allergic conjunctivitis which becomes worse in summer season. So what is your diagnosis based upon this information, beta? What is your diagnosis based upon this information? Yes, we are talking about vernal keratoconjunctivitis or spring catarrh, right? So we are talking about vernal keratoconjunctivitis or spring catarrh. And there can be sometimes an additional symptom given to you, like there is a ropey discharge. So if they mention ropey discharge, again it is a diagnosis like this, beta. It's a diagnosis like this. Okay? So this is most likely the condition discussed in the statement. Now coming to the image here. What do you see in the image here, my dear friends? So you see the eye is red, and then you are seeing these raised lesions around the limbal area. You are seeing these raised lesions around the limbal area. See here, beta. These gelatinous raised lesions around the limbal area here. So these are your Horner-Tranta spots. These are your Horner-Tranta spots, friends. Okay? So which is seen in the cases of VKC. So that combines beta the VKC based upon the symptomatology, and what we are seeing here is Horner-Tranta spots. Horner-Tranta spot, which are the gelatinous papillae type lesions around the limbus seen in VKC. Fine? Are we clear? Are we all clear here bache? Coming to the other options, it's not a phalectin. I'll just show you how the phalectin look like. It's not a Herbert pit. Herbert pit is seen in trachoma. It's not a bited spot. Bited spots, they are seen in vitamin A deficiency or xerophthalmia. Okay? Let me take you through the differential diagnosis of different type of the lesions which you see in the limbal area or close to the limbal area. Okay? So that if any question related to that comes, so that's easy for us to attempt. So this is how your phalectin will look like, bache. This is how your phalectin is going to look like. So phalectin is seen in phalectanular conjunctivitis. You know, it's a hypersensitivity reaction to either a staph antigen or a tubercular antigen, and they will appear as isolated nodular like lesions around the limbus. Okay, so mostly they are not located at the superior limbus, they will be elsewhere. So isolated nodular lesions around the limbus. Fine. They do not have any seasonal this thing, so the question will be giving you a clue whether it's a seasonal allergy or something like that. Here is how your Herbert pit look like. So pit kya hoti hai beta? Pit is a depression. Pit is an area where there is thinning of the tissue. So here if you notice, the lesion is not raised. It is a pit-like lesion. Thinning, that is why it is appearing little blackish in this area. Thinning. So these are your Herbert pits. The Herbert pits, they are seen in the healing stage of trachoma. Got it? Right? Then, this is your, everyone, what is this lesion beta? This lesion is a white foamy lesion, not at the limbus, it is on the bulbar conjunctiva in the temporal area. So this foamy lesion is the spot diagnosis for bited spot beta. This foamy lesion is a spot diagnosis for bited spot, which is seen in vitamin A deficiency. Now, at this moment, let's revise another lesion which can be found in the limbal area. So here you see it is the limbal dermoid beta. This is how a limbal dermoid, which is a benign tumor, will look like. Again, it is usually present in the limbal area. Of course, the name is limbal dermoid, but here the eye will not be congested. It's a benign tumor. So again, this can also be asked as a spot diagnosis. Okay, are we good here, bache? So this is your revision of the lesions related to the limbal area. I showed you the question had this Horner-Tranta spots here, and I have shown you the phalectin, the Herbert pit, the bited spot, and the limbal dermoid. Okay, ji? Okay, right? So are we ready to move ahead here? Moving to the next question, bache. Moving to the next question. A very easy, straightforward question. Which of the following will confirm the diagnosis in a young man presenting with given fundus finding? Presenting with given fundus finding. So, let's go to the fundus finding, beta. Let's go to the fundus finding. What do you see here? What do you see here in the fundus? So what you're seeing here is the fundus beta. In fundus, always go step by step. Optic disc is normal, blood vessels are normal. Coming to the macular area, you are seeing a yellowish spot which is looking like a, do not jump to the conclusion beta. You do not jump to the conclusion. immediately. So it is not a central retinal artery occlusion. My dear friends, in central retinal artery occlusion, the retina will appear pale because of ischemia. Cherry red spot, beta. Cherry red means reddish. It has to be like a cherry. This is not a reddish spot. What is this, bache? This is a yellowish spot. This is a yellowish spot. Bullseye. Bullseye का मतलब क्या होता है बेटा? Bullseye is your target. So it has to have a ring, white and black ring like a target. Yes, very good, Mr. Sean Parker, Dr. Sean Parker. So far, I have got one answer here, which is your best disease. Which is the right answer here, beta? What is the right answer here? Okay, so it's the yellow spot in the macula. And this yellow spot in the macula is looking like what we call as egg yolk appearance, bache. Egg yolk appearance. है ना? Egg, boiled egg का yellow yolk like appearance. Fine. So this is egg yolk appearance which you see in the cases of Best disease, bache. Okay? So no problem if you could not make it the right diagnosis at the moment, but I hope now all of you will be able to identify if this comes in your exam, because this can come as a spot question also, bache. Okay, so retinitis pigmentosa, you all know how the retinitis pigmentosa with those bony spicule looks like, but please do also remember how the best disease looks like, बच्चे. ठीक है? नहीं, डोंट वरी डॉक्टर चेकअप, कुछ मिक्स नहीं होगा. अभी मैं आपको CRAO, CRAVO सबके फंडस फोटोज आई एम गोइंग टू शो यू सो दैट एवरीथिंग इज रिवाइज्ड. द पर्पस ऑफ दिस सेशन, माय डियर फ्रेंड्स, इज टू रिवाइज. Okay, so among 19 subjects, ophthalmology is one subject. So obviously, it needs revision in between, and that's what we are going to do. It's okay to do mistakes here. It's okay to do mistakes in your mock test. It's okay to do mistakes in your grand test while you're revising. When you do mistakes, you learn. And when you learn, that is going to help you in your exams. Okay? So no worries at all. No worries at all. Yes, very nice, Dr. Rushik. It's juvenile vitelliform dystrophy. Okay, so in Best disease, what happens? There is a deposition of what we call as lipofuscin material in the macular area. Rest everything will be normal. Okay, in vascular diseases, there will be other changes. So here rest everything is normal, just that yellowish deposit in the macular area. So it's called egg yolk appearance, which is seen in Best disease. It's a type of hereditary retinal degeneration. Okay, and for the retinal degenerations, beta, we do electrophysiological test. The investigation of choice to diagnose Best disease is your choice C, beta, electrooculogram, or we also call it as EOG. ठीक है, ये जानने की जरूरत नहीं है for us that what is electrooculogram exactly. It's an electrophysiological test which measures the sort of electrical retinal activity. EOG is the test which is confirmatory for Best disease. ठीक है, right? Great, very nice. Coming to the other choices, electroretinogram or ERG. If you remember, beta, this is a test for retinitis pigmentosa. Okay? This is the test for retinitis pigmentosa. Then visual evoked potential. It is a test which we do for optic nerve diseases. Visual evoked potential is the test which we do for optic nerve diseases. And fundus fluorescent angiography is usually done for the retinal or choroidal vascular diseases. Fine. So this question is making you learn what is Best disease, how Best disease looks like, and what is the investigation of choice for Best disease. ठीक है, अब मत भूलना बेटा अगर ये एग्जाम में आए तो. All right, let's move to the next question. Let's move to the next clinical case scenario. A young man comes with a painful red eye and blurred vision for last 4 days. Now again, go step by step, word by word, spend few seconds on the question statement. A young person comes with painful red eye and blurred vision. So painful red eye, decreased vision for last 4 days. Slit lamp examination shows aqueous flare and cells. So when do you see the flare and cells, beta? It means there is inflammation. Okay, aqueous flare and cells, they are seen in anterior chamber inflammation. On examination, this is the fundus finding which is seen, which you are seeing here. Fundus, not the fundus finding, sorry, slit lamp finding which are seeing here. Fundus is normal. So what will be the drug of choice for treating this condition? So again, this has two parts. First of all, make a diagnosis and then choose your drug. So how I am going to make the diagnosis, beta? Come to this picture. Again, this can be asked as a slit lamp image based question also. Now coming here, so it was red eye with pain and decreased vision. So this was the symptom. Okay. In the signs, what they have told that there are aqueous cells and flare, and then rest of the things they say pick up from this image. So what do you see here, bache? So first of all, what is most striking which you are seeing here? See this pupil which is irregular. This pupil which is irregular. So this irregular pupil is because of the posterior synecdoche, bache. This irregular pupil is because of the posterior synecdoche. And then if you notice clearly, there are seen these deposits on the corneal endothelium, which are your keratotic precipitates. Fine. So if you are able to identify posterior synecdoche because of the irregular pupil, so there are posterior synecdoche, and you are able to see keratotic precipitates which are hallmark of. So all this is fitting into the diagnosis of, my dear friends, acute anterior uveitis. Okay, all this is fitting into acute anterior uveitis. So if you see, yeah, this is absolutely right, Dr. Chaudhary. This is like a festooned pupil. These are big KPs. So you can call them as mutton fat KPs. Very nice. So painful decreased vision, red eye due to circumcorneal congestion, aqueous cells, flare, KPs, posterior synecdoche, feature of acute anterior uveitis. Okay. Now coming to the question, what is the treatment, beta? What is the treatment for acute anterior uveitis? It's an inflammatory condition. So why I am saying it is anterior uveitis? Only because fundus is normal, everything else is normal. So here, even the eye drops will be sufficient. What kind of eye drops you want to give? You want to give eye drops which will control the inflammation. And what are the strongest anti-inflammatory drugs? Steroids. So you will give topical steroids. But will you give topical steroids only? No, because there is posterior synecdoche, there is ciliary spasm because of the inflammation. So you want to do cycloplegia also. You want to relax the ciliary muscle, because releasing the ciliary spasm will help in reducing the pain, reducing the inflammation, as well as breaking of the posterior synecdoche. Okay, so the treatment which is ideal for this condition is topical steroid and atropine. ठीक है, नहीं बेटा सिर्फ टॉपिकल स्टीरॉइड्स नहीं, because you will combine it with a strong cycloplegic drug like atropine, as I explained. So I'm sure all of you are clear. So this question helps you to make a diagnosis based upon the clinical case statement, based upon the signs, and also let you know about the treatment. ठीक है जी, time to go forward. Okay, so okay beta, ध्यान से देखना अब ये क्वेश्चन भी, don't jump to the answer. This question is showing you 4 type of the surgical instruments, and you have to tell me which instrument is not used during the cataract surgery. Which instrument is not used during the cataract surgery? Okay, so for your this thing, I'm going to enlarge the picture one by one, and you have to kind of like, tell me. So this is your figure one, beta. Can all of you identify this instrument? This was in the last exam, bache. This was in your July exam. So can you identify this? This is called as wire speculum, beta. Okay, so this surgical instrument is called wire speculum. It is used to keep the lids open during any ocular surgery, especially for the intraocular surgery. ठीक है जी? So figure one हो गया ये वाला. Now figure two. The figure 2 is showing you a forceps. If you see clearly, beta, here, this forceps is a plain forceps. This forceps has an angle like this, and it is a plain forceps, no teeth. So this is your McPherson forceps, bache. McPherson forceps. Now, McPherson forceps again is used in the cataract surgery. It is used to hold the intraocular lens during the implantation. It's also used to guide the intraocular lens into the capsular bag, and also used for helping the corneoscleral suturing. So, McPherson forceps. Okay. Moving on to figure 3. Now, figure 3. Now, this forceps has fine teeth, beta. This forceps has fine teeth. It is called corneoscleral forceps, and this particular one is called limbs forceps, beta. Okay, so it has fine teeth, is corneoscleral forceps, again used in cataract surgery, glaucoma surgery. When you want to hold the corneoscleral tissue, you use this forceps. Okay, now coming to figure 4. So what are these? The metallic thin instruments, you can say, the structures. So these are your lacrimal probes, bache. Probes. They are a Bowman lacrimal probe or Bowman nasolacrimal probe, which is used for the nasolacrimal probing, syringing and probing in congenital nasolacrimal duct obstructions. Remember, you do syringing and probing. So these are the one. Okay, not in DCR, beta. They are used for syringing and probing. They are used for syringing and probing. ठीक है जी? So obviously syringing and probing is not required for cataract surgery. So which of the instrument you will not use during the cataract surgery? Figure 4. ठीक है? So if a question related to this comes, so you know the main instruments used for the cataract surgery, and you have to rule out the one which is not used. Great. Perfect. Ji. Moving on to the next question, bache. Moving on to the, for DCR, the instrument which they usually show is a bone punch, beta. A DCR bone punch, which is used to fracture the bones of the lacrimal fossa. Great. Let's move to the next question, my dear friends. A child presents with leukocoria and is diagnosed with an intraocular mass with calcification filling more than half of the eyeball. Again, a classical book question, very important question, can come in different forms. So let's see. A child with leukocoria. ठीक है, अब child with leukocoria आए तो the which bell should ring in your mind? Along with other features, intraocular mass with calcification. Just this much information is okay for making a diagnosis, बेटा. ठीक है, ये 3 वर्ड जब एक साथ आ गए, ल्यूकोकोरिया, इंट्राओक्युलर मास विद कैल्सिफिकेशन, ठीक है, ये 3 वर्ड अगर एक साथ हैं, the diagnosis is retinoblastoma. Okay, so I have already made my diagnosis that it is retinoblastoma. ठीक है, चाइल्ड है, बच्चा है, the tumor, the intraocular malignancy of the children is retinoblastoma. Now the question is based upon the management. Now this mass is filling more than half of the globe, so the tumor is big in size. It's filling more than half of the globe. So what is the ideal management of this case? Now when this is the information given. So this tumor falls into group E according to the International Classification of Retinoblastoma, beta. According to ICRB, the tumor filling more than 50% of the globe. Besides that, when there is anterior segment invasion, when there is the orbital cellulitis like picture related to retinoblastoma, orbital invasion, all those they come into the group E tumor. And for group E tumor, the treatment is E for enucleation. Okay? So the treatment, the right answer, as all of you have told, is enucleation. Fine. Now coming to the other options, chemotherapy is given either to do chemo reduction, that when you want to reduce the size of the tumor before giving the focal therapy or brachytherapy, or as a palliation when there is orbital invasion. Laser is used for smaller tumors, mostly for group A or some group B tumors. Radiotherapy is given when there is orbital invasion or optic nerve invasion, then you give the radiation to the orbital apex. Okay, so coming here, beta, just a quick recap of the things related to retinoblastoma. This is how the clinical presentation is. The most common clinical presentation is leukocoria, the intraocular mass with calcification. Usually, if it is an endophytic tumor, it will appear like a cauliflower-like mass growing from the retina into vitreous cavity. Okay, so calcification is seen in retinoblastoma. On histopathology, one, if the child required enucleation and you did histopathology and you find this kind of the histopathology pattern or differentiation, what you are seeing here is beta Flexner, Wintersteiner, Rosette. So which are highly specific of retinoblastoma. So Flexner, Wintersteiner, Rosette. Okay? Now just to summarize the treatment, from group A to D tumors. So you can give focal therapy plus minus chemotherapy. If the tumor is large, you will first do chemo reduction and then do focal therapy. So focal therapy can include laser, it can include cryotherapy, thermotherapy, brachytherapy. But once it is group E stage, then you have to, as we just discussed, enucleation. Okay, dear friends. So anything related to retinoblastoma treatment, diagnosis, I hope everything should be clear here. And don't miss it also. Usually it's a very easily attempted question. Let's move on to the next question, beta here. Let's move on to the next question here. A diabetic patient has developed recent onset drooping of the lid. Again, diabetic patient, recent onset drooping of the lid. Okay, drooping of the lid means, what is drooping of the lid, bache? Ptosis. So the patient has developed ptosis. Fine. The eye is in down and out position. Eye is down and out position. Why the eye is in down and out position? Because it means that all other muscles, they have extraocular muscles, they have paralyzed, except for the muscle which moves the eye outward and the muscle which moves the eye downward. So which of the following will be suspected in this case? Very nice. So such a nice to know that every one of you is giving the right answer here, because again these are the key words in this question, beta. Ptosis, down and out eye, there is no doubt it means it is a third nerve paralysis. It is a third nerve paralysis because all the muscles, bache, all the muscles except lateral rectus, which is supplied by sixth nerve, and superior oblique, which is supplied by fourth nerve, they are paralyzed. Extraocular muscles are paralyzed except these two. Okay, so because of this, because lateral rectus moves the eye outward and superior oblique in abducted position, it is the eye which, because the downward action of the superior oblique will be unopposed, so that is why it moves it down and out. Okay, so this is how a patient of third nerve palsy will look like, beta. Here the patient is having, this is the left eye of the patient, so he is having left third nerve paralysis. So here if you see, the lid is in normal position, here there is ptosis, partial ptosis, here the eye is in down and out position. Okay, right? Yes, the ptosis is because of the LPS paralysis. The ptosis is because of the LPS paralysis. Very nice. Okay. Coming to the other choices, just to kind of have additional information, oculosympathetic paralysis. So oculosympathetic paralysis is beta what you see in Horner syndrome. So in Horner syndrome, the oculosympathetic paralysis is there, due to which there is weakness of the molar muscle. So again, you will get mild ptosis, but there will be other extraocular muscle action will be normal. In sixth nerve palsy, it will be lateral rectus palsy. So the eye will be not be able to move outward, abduction will not be possible, so there is a medial convergent squint or convergent squint. In fourth nerve palsy, it is the superior oblique muscle is paralyzed, so the eye goes into hypertropia. The eye goes into hypertropia. ठीक है जी? Right? Perfect. Okay, so you'll be able to identify third nerve or the other muscle paralysis based upon this information. Okay, let's go to the next question, beta. Let's go to the next question. Again, a question related to cataract surgery. Now, cataract surgery related questions, they have been coming now for last few times, beta, in almost all exams. FMG, NEET PG, INICT. So, cataract surgery is one topic which you should know nicely. Let's revise a question related to that. A surgeon is performing cataract surgery on a 60 years old patient and he asks for viscoelastic substance from the assisting nurse. Okay, so cataract surgeon ne bola, give me viscoelastic during the cataract surgery. Which of the following statement is not correct regarding the use of the viscoelastic during cataract surgery? Okay, which of the statement is not correct? Now, if you remember just a quick recap of the steps of the cataract surgery, whatever is the technique of cataract surgery, you have to make an incision. Okay, so you make an incision and you enter the anterior chamber. Okay, now as soon as you will enter the interior chamber, तो क्या होगा बेटा? As soon as you enter the interior chamber, the aqueous will flow out and the interior chamber will collapse. So you have to inject something to maintain the interior chamber. So that is what you do. Viscoelastic substances, they have that volume that they will maintain the interior chamber. Then other thing is, when you are using the instruments in the interior chamber, you can cause injury to the corneal endothelium. And especially elderly people, especially the people who have already existing endothelial dystrophies, for example, Fuchs endothelial dystrophy, they might have more endothelial damage during surgery. So to prevent this endothelial damage, again, these viscoelastics, they coat the inner surface of the cornea, that is endothelium, and they protect corneal endothelium. Okay, then when you are you did your surgery, when you want to put the intraocular lens, you want to expand the capsular bag to make a space for the intraocular lens. Again, you put viscoelastic agent. Okay, but the purpose of the viscoelastic agent is to help us in these steps during the surgery. Okay, during the surgery, these are considered to be inert substances, but once the surgery is over, you have to wash them out, beta. You have to wash them out. Why? Because these are, like, you can say viscous. When I call viscous, it means they are thicker, more viscous than aqueous. So they can cause high intraocular pressure if you do not remove them after the surgery. And at the same time, sometimes they can even cause inflammation after the surgery. Okay, so once their work is over, एक बार उनका काम जब हो गया, so do not leave them in the eye, remove them at the end of surgery. ठीक है, right? So I think I have already explained you the right answer here. So the choice A, let's see which is the false statement. They are used to protect corneal endothelium. That is true. They are used to maintain interior chamber during the surgery. That is true. Sodium hyaluronate can be used as a viscoelastic. So please remember, sodium hyaluronate is one type of the viscoelastic. That is true. They need not to be removed after the surgery. Now this is false because they need to be removed. So this is the answer here, beta. Okay? So I'm just going to explain it. They are used to maintain the interior chamber, because once you make the incision, the aqueous flows out. So to maintain the interior chamber so that you can perform the capsulorhexis, intraocular lens implantation, there should be space in the interior chamber. So that is why you inject them. They provide a protection to the corneal endothelium so that there is no damage because of the surgical instruments during the cataract surgery. And you will remove these because they can cause high intraocular pressure in the post-op period, and rarely they can also cause inflammation or uveitis because of, like, persistent viscoelastic in the interior chamber. ठीक है जी, right? So just to let you know, the some of the viscoelastic substances which we use during the surgery, during the cataract surgery, the name they include sodium hyaluronate, as it was there. So sodium is one of the most commonly used and very good viscoelastic, you can say. Then we also use a little cheaper one. Methyl cellulose can also be used as a viscoelastic. And then chondroitin sulfate is another type of the viscoelastic which is used. So sometimes the combination of sodium hyaluronate and chondroitin sulfate is used. ठीक है जी? Yes. So trypan blue is another, you can say, thing which is used during the cataract surgery. The trypan blue is used to stain the interior capsule. है ना? Stain the interior capsule, especially when there is mature cataract, to assist in capsulorhexis. Fine. Let's move to the next question, beta. A 55 years old male patient with history of hypertension, smoking presents with painless loss of vision in the left eye. Okay, so you can get a question based upon the clinical case scenario and a fundus image. So let's see what is this question about. So what we are seeing here is that there is this patient who is 55 years of the age, hypertension and smoking. ठीक है, अब आपको पता है बेटा, हाइपरटेंशन है तो there will be risk of vascular diseases of the retina. Again, smoking है, smoking will also be having a risk of vascular diseases of the retina, because smoking is a factor for risk factor for thromboembolic phenomena, है ना, right? So this is the risk factor in the history. Now, painless loss of vision in the left eye. So painless loss of the vision, beta, fundus examination is shown here. Let's see the fundus examination. So now in this case, the fundus picture is your diagnosis, beta. Okay, so in this case, the fundus picture is your diagnosis. So let's move on to, like, see that what is the diagnosis in this case. So what do you see in the fundus picture, my dear friends, here? What do you see in the fundus picture here? So you are noticing that there are multiple retinal hemorrhages. Okay, so you see that there are multiple retinal hemorrhages, and those hemorrhages, they are located only in one quadrant, है ना? they are located only in one quadrant of the retina, not in all over retina. Okay? So whenever these multiple retinal hemorrhages beta, so it means there is some vein occlusion. Okay? जब ऐसे scattered multiple retinal hemorrhages हो, so please see that there is a possibility of vein occlusion. And then when they are located to one quadrant, it means it's a branch retinal vein occlusion. Okay? Right? So it's a case of branch retinal vein occlusion in a hypertensive patient. It because there is macular edema in these cases and hemorrhages in the macular area, that will cause a painless loss of vision. Good, right? So this is not a CRVO. CRVO कैसा होता है अब वो भी अभी देख लेते हैं. Okay, so answer here, my dear friends, is branch retinal vein occlusion, your choice C. And let us now move on to that how the other conditions they look like. How the other conditions they look like. Let me take you through that. This is what is beta central retinal artery, vein occlusion. ठीक है, सेंट्रल रेटिनल वेन occlusion, जैसे अभी आप बता रहे थे टोमेटो स्प्लैश अपीयरेंस और blood and thunder appearance. You see here the retinal hemorrhages, they are scattered all over the retina as if somebody has thrown a tomato which has splashed over the fundus. Okay, जब ऐसा है so this will be central retinal vein occlusion. Again this patient will present with sudden painless loss of vision. Okay, so Dr. Harihar Sudan, I'm sure now it is clear that why the previous picture. So see the difference between this image where there are hemorrhages only in one quadrant. This area is normal, this area is normal, this area is normal. Okay, and the difference between here where you see hemorrhages all over. So the first one will be branch retinal vein occlusion. This one will be central retinal vein occlusion. How the artery occlusion looks like. Okay, I always tell beta, when artery is blocked, artery is the source of blood supply to that tissue. When artery is blocked, it means there is no blood supply in that area. When there is no blood supply in that area, it will become ischemic. Healthy retina gives a reddish appearance. A pale ischemic retina will appear like this. Ischemic retina will become whitish, pale. Okay, so when you are seeing this white, pale retina with the cherry red spot, so this is the cherry red spot, beta. Okay, here what you are seeing here, my dear friends, is your cherry red spot. So when you are seeing pale retina with cherry red spot, this is your central retinal artery occlusion, right? So I hope none of you will make a wrong diagnosis, whether you get a branch retinal vein occlusion or you get a central retinal vein occlusion or you get a central artery occlusion. Okay? All three are very, very different if you look carefully on the fundus picture. All three will present with painless loss of vision. Fine? Yes. And coming to the last choice which was there in the image, vitreous hemorrhage. Now what you are seeing here, beta. So here you see the blob of the blood, the big clots of the blood, they are floating in the vitreous cavity. So this is vitreous hemorrhage. The blood clots, they are obscuring the view of the retina. They are obscuring the view of the retina. So this is how a vitreous hemorrhage will look like. Now the vitreous hemorrhage will be seen, it can be seen, lot of conditions, it can be seen as a complication of proliferative diabetic retinopathy, as I told you. It can happen as a complication of CRVO also. It can happen due to trauma also. It can happen in Eales disease also. Okay? Right? Okay, so one of you is asking me how the branch retinal artery occlusion will look like. So again, beta, why did I not put a picture of that? Because that's not expected to be asked. But then again, what is your common sense saying? In branch retinal artery occlusion, it will be one quadrant of the retina which will be pale and rest will be normal. Okay, because it's the branch. So the area where that branch retinal artery is supplying will appear pale and the rest of the retina will be normal. and it may not have cherry red spot depending upon which branch is occluded. Great. Okay, so this has covered all of your fundus, most of your fundus spot diagnosis beta. Okay, and now is the time to revise another important aspect which can be asked in the exam related to the refractive errors, bache. Refractive errors. Here, coming here. A 5-year-old girl underwent retinoscopy under atropine done at 1 meter working distance. Which of the following option describes her refractive error? So I just put a question which will tell you how to calculate the glass prescription from a refractive retinoscopy finding, how to identify the type of the refractive error, and also getting to know whether it is with the rule astigmatism or against the rule astigmatism. Okay? Oh my god, some of you are already on to the answer. It's going to take me time to give you the answer. Let's not rush. Okay? आ जाइए बेटा, यहाँ पे आ जाइए. So this is the scenario, and your question has described that working distance is 1 meter and this retinoscopy has been done under atropine. Okay, so you know, to give a glass prescription you have to correct for the working distance and you have to apply correction for the cycloplegia. So for 1 meter of working distance, the correction which you will apply will be -1 diopter. Okay, and for atropine also the correction which you will apply will be again -1 diopter. Okay, so it means you have to subtract -1 here, -1 here, -1 here, -1 here. ठीक है, तो क्या बन गया आपका? The corrected cross क्या बन गया? Yes, very right, very right. Who is there? Dr. Jacob. Yes, corrected cross will be +3 diopter and +1 diopter. Okay, so this is the corrected cross and you have to give glass prescription based upon this. Okay, अब यहाँ पे ही आप देखें, there is a different correction for vertical meridian. So this is your vertical meridian beta, 90-degree meridian, and this is the horizontal meridian, 180-degree or 0-degree meridian. So there is a different correction. So it means there is astigmatism, because if it is same on both the meridia, then it is no astigmatism. If this would have been +1 on both or +3 on both, then there is no astigmatism. But here it is +3 at vertical, +1 at horizontal. So it means there is astigmatism. So it means you will give spherical correction, but you will have to give a cylindrical correction for the astigmatism. Now, how to choose the spherical correction in the glass prescription? The smaller numerical value. The smaller numerical value will be used as a spherical correction. ठीक है जी? So it means +1 diopter sphere will be given in the glass. Now when you give +1 diopter sphere, the sphere is going to provide that correction all over 360-degree. But vertical meridian will still be under corrected with +1. So it means vertical meridian will be requiring +2 more here, +2 more here. So you will be giving +2 diopter cylindrical. Okay. Now this cylindrical is required at vertical meridian. It will be placed in the glasses at 180-degree. Okay, because it is required at 90-degree or vertical, but the placement of the cylinder will be at 180, because action of the cylinder is perpendicular to the axis where you place it. Okay, glass prescription में when you place a cylinder at 180, it actually is providing correction at 90-degree. So this will be the correction here. Okay, so this will be the correction here. Okay, now what is the type of the refractive error here beta? There is plus as a sphere, there is a plus as a cylinder. So plus glasses, they are used for hypermetropia. Convex glasses or plus glasses are used for hypermetropia. So this will be a compound hypermetropia. Agree, beta? Each one of you agree with me? It will be a compound hypermetropia. Okay. And if I have to define which type of so compound hypermetropic astigmatism is what is called as, which type of the astigmatism it is. There is a plus at 180. Okay, there is a plus at 180 degree which makes it against the rule astigmatism. Okay, very nice. So compound hypermetropic astigmatism against the rule. With the rule, against the rule कैसे पहचानना है बेटा? इस टाइम पे, at this point of your time of your preparation, do not go into this thing much explanation. Just remember this: if it is minus cylinder at 180, that is with the rule. If it is plus cylinder at 180, it is against the rule. ठीक है, बस यही आप कर दीजिए. ठीक है बेटा, right? So minus cylinder at 180 is with the rule, plus cylinder at 180 is against the rule. ठीक है, Trupti, I will go with another example, but at the end of the session, so that you will get to know it again. But here is everything clear to all of you what I explained here, bache? So what is my right answer here? So my choice here is choice C. My right answer here is choice C. It is compound hypermetropic astigmatism against the rule. ठीक है जी? So in these kind of questions, beta, I always recommend that do not read the choices first because you will get confused. पहले इसको numerical की तरह solve कर लो. Okay, so just solve it and then match your answer with the choices. Good? Okay, perfect. Moving on to the next question, bache. Moving on to the next question. Very easy one. It's the easy question I don't think you will get, but you do get these easy questions in the exam. Which of the following is not seen in an eye in case of vitamin A deficiency? Okay. So इस question को attempt करने के लिए you should know what are the signs and symptoms which happen in vitamin A deficiency in the eye. So not seen. Again, it's very important in your exam to look at when you see something like not seen, not found, not correct. Okay, so do not miss those words to do silly mistakes in the exam. Okay, so what is not seen? Bited spot. Do you see bited spot in vitamin A deficiency? Yes. Nyctalopia. Nyctalopia means night blindness. Do you see? Yes. Peripheral visual field loss. So that's not a feature of vitamin A deficiency. That is the feature of retinitis pigmentosa. Okay, so happy. All of you are giving me the right answer for this question. So happy. So it means any question related to vitamin A deficiency, don't mark it wrong. Corneal xerosis, the dry cornea, that will be seen. Okay, so let's have a quick recap of this, my favorite chart for xerophthalmia. Xerophthalmia is a collection of all the signs and symptoms which you see in the eye because of vitamin A deficiency. This is the WHO classification. The first symptom is night blindness or nyctalopia. The first sign is conjunctival xerosis, the lusterless, dry looking conjunctiva. Why? Because the goblet cells, they are damaged. So the eye is becoming extremely dry. Then bited spots, corneal xerosis, cornea becoming extremely dry, corneal ulceration or keratomalacia, whether initially X3A it involves less than 1/3 and in X3B it involves more than 1/3. Ulceration will lead to scarring. In the fundus, you see pigmentary changes, but they do not cause any peripheral visual field loss. Okay, right? Okay. Fine. So moving on to the next question, beta. Again, a very easy question. Sometimes you get confused in these questions. Let's do it so that there is no mistake in attempting these kind of questions. Which of the following is the synergist muscle of medial rectus in the right eye for abduction? Okay, synergist muscle. Now, when we talk about the synergist muscle, so the synergist muscle, simple I say, synergist muscles mean same action, same eye. SSS. So a muscle which is doing same action in the same eye will be synergist. That will be a synergist pair. Okay. So medial rectus causes adduction. So among the choices, which one is the synergist muscle in the right eye for medial rectus? बेटा carefully करना है. Synergist of the medial rectus in right eye for adduction. Okay. So some of you are getting me the right answer. Some of you are confusing it with the yoke muscle. So that was the idea behind this question, to clarify these doubts for you. So those who are saying A, they are giving me the right answer. ठीक है, देखो बेटा ये सामने लिखा है ना, synergist muscle. Synergist has to be of the same eye. So if my question is asking me synergist muscle of the right eye, then that muscle has to be in the right eye. ठीक है, तो ये left वाला तो वैसे ही निकल गया. Then the muscle should have same action in the same eye. The muscle should have same action in the same eye. So what are the adductors? Which muscles are the adductors? Okay, the medial rectus, superior rectus and inferior rectus. है ना? When we say recti are adductors, वो synrad भूलना नहीं है बेटा. This is a very important mnemonic for all the muscle action related question. Very important mnemonic for all the muscle action related questions बेटा. ठीक है, superior muscles are intorters, recti are adductor. ठीक है, अब वो recti में lateral rectus को निकाल दो. Okay, so except lateral rectus, that is been already know is an abductor. So other recti are adductor. So means the adductors will be medial rectus, superior rectus, inferior rectus. So here when we are talking about synergist muscles for adduction to the right eye, medial rectus, the answer will be right superior rectus. अब clear हुआ बेटा? Right? Lateral rectus तो abduction करती है. So this is an antagonist. This is an antagonist to the medial rectus. Okay, superior oblique भी abduction करती है. So it will be also an antagonist, not synergist. And the synergist muscles, they have to be in the same eye. So we are not talking about yoke muscle beta. Okay? So first of all, clear the concept of synergist muscle, and then we will quickly see what are the yoke muscles. So this is like, how you will see synergist. So synergism will be for a particular action. So for example, for elevation, both of these, superior rectus and inferior oblique, will be synergist muscle. For depression or for downward movement, inferior rectus and superior oblique will be synergist. For adduction, first of all, let's do adduction. So for adduction, the recti, the medial rectus, inferior rectus and superior rectus will be the synergist. ठीक है, ये clear हुआ बेटा? Now for the yoke muscles. Now coming to the yoke muscles, the yoke muscles are pair of the muscles. So these are pair of the muscles in each eye. So there will be one muscle in one eye, other muscle in the other eye for same gaze. So same gaze means when you want to move the eye in a particular gaze. So both eyes they move together. है ना, ऐसा तो नहीं है कि one eye is moving towards right and the other eye will move towards left. So both eyes they have to move in the same direction. So there will be one muscle in each eye which will be making the eye move in that direction. Fine. So I'll give you an example here. So for example, levo elevation. For example, levo elevation. Now, levo elevation means you want to move the eye left and up. So both eyes, they should go left and up. So when that is there, so left eye will be using the superior rectus. So same side superior rectus will be used. When you want to move the eye left and up, the same side rectus muscle will be used. So which rectus moves the eye up? Superior rectus. So left eye superior rectus will be used, whereas right eye inferior oblique will be used. So convert superior into inferior, rectus into oblique. So these will be the yoke muscles for the left and up action. Okay, so in yoke muscle, one muscle will be of the right eye, one muscle will be of the left eye, and depending upon which is the gaze which you want to use, so for left and up, same side rectus will be used. So you get one muscle, so left superior rectus. The other you can convert by simple conversion, make left as right, make superior as inferior, make rectus as oblique. ठीक है जी. Just to give you one more example of the yoke muscle. So for example, you want to know the yoke muscles for dextrodepression. Dextrodepression. So dextrodepression means you want to move the eye right and down. ठीक है. So right and down move करना है. So same side rectus. Which rectus moves the eye down? So right eye inferior rectus will be used. So this will be one muscle of the yoke muscle pair. In the left eye, make right as left, inferior as superior, rectus as oblique. So this will be the pair of the yoke muscles for dextrodepression. ठीक है. So yoke muscles, they have to be one muscle in each eye. Synergist muscle is the muscle in the same eye. Muscle in the same eye. I hope I am clear, and I hope that you will be able to do the question related to yoke muscle or synergist muscle, or any question related to the muscle action. Okay? Right? Okay, perfect. So here is beta. Here is something which I want you to share with, like, some thought here. So obviously we have been, like, putting a lot of hard work, and the goal is to crack the exam and to be called as a doctor in our own country. Okay. So whenever anybody sets a goal for himself or herself, there are 3 stages, beta. There are 3 stages to achieve that goal. Okay. हम सबका goal क्या है? To clear the January 2025 exam. Okay. So this goal began with a conviction. The first step. Okay. What are the 3 steps to achieve that goal, beta? The first step is the conviction. Conviction means अपने आप पे ये भरोसा, ये trust that yes, I can. Okay, so this is my goal here. Yes, I can. You already know, so that's why you started preparing. The second step is to maintain that conviction. है ना, बड़े ups and down आए हैं, बड़ा thoughts आए हैं, कर पाएंगे, भूल रहा है, रिवाइज कर रहे हैं, सब कुछ भूल रहा है, क्वेश्चन गलत हो रहे हैं, बट जो कन्विक्शन, जो ट्रस्ट आपने, जो फेथ आपने अपने आप में रखा है, मेंटेन दैट बेटा. सो दैट इज दैट यस, I will, till the January exam, I will keep on putting my best effort, my best use of time to achieve my goal. और जब एग्जाम खत्म हो जाएगा, you got your result, then you will be able to say, yes, I did. And you will be sending us messages that, yes, I passed my exam. ठीक है? So keep these 3 steps in your mind, beta. पहला, already आप, when you started preparing, you imbibed that. You can, definitely you can. I'm very sure you will do the best during this phase of preparation and your best during the examination. Okay? And I'm waiting for the day when you will message me, yes, I did. Okay? So with this spirit in mind, let's go ahead. Again, an image-based question for you, beta. Identify the finding shown in the given slit lamp image. Now, this is a slit lamp image. So when in the slit lamp image, bache, I've been always telling you what you need to see. Go step by step. Okay? In this image, the conjunctival area is not seen. So we are straightway looking at the central part. Cornea is clear. How do I know the cornea is clear? Because I am able to see the iris detail and the lens detail in this image. So cornea is clear. Iris is not showing any significant abnormality. What I am seeing here is some changes on the lens surface. These kind of exfoliated material and some white fibrillary material deposited at the center of the lens. What is your diagnosis, beta? When you see this type of picture, again, my dear friends, do not jump onto the diagnosis. Let me take you through the choices one by one. Is it a zonular cataract? It's not a zonular cataract because this central area which you are seeing is not the cataractus area. It is on the surface here. Zonular cataract is a type of congenital cataract. Is it a Vossius ring? Beta, Vossius ring is a pigment ring, brown pigment ring. So this is not brownish in color. So this is not a brown pigment. Is it a ring ulcer? So ring ulcer is a corneal ulcer mostly seen with acanthamoeba. So the cornea is clear. Here the changes, they are on the lens surface. So what you are seeing here, as you have now told me, is pseudo exfoliation. Now pseudo exfoliation is a condition in which the lens capsule, it shows deposition of the fibrillary material, which you see like this. So there will be this whitish fibril means like you can say dandruff like material. So that can be present, if you notice very carefully, even at the pupil margin, though I don't expect you to see that, but on the lens surface you are able to see. So this is pseudo exfoliation, white dandruff like material you can say, or we can say fibrillary material which is seen on the lens capsule, and this gives it a typical appearance also. This is also called as target sign, beta. The target sign which you get in pseudo exfoliation. Okay? Right? Fine? So if something related to this comes, so please be able to identify this is your target sign which you are seeing in pseudo exfoliation. Now the people with pseudo exfoliation, they can have a glaucoma, a secondary glaucoma, which is called pseudo exfoliation glaucoma. They also have weak zonules which can lead to subluxation of the lens. Okay, bache, time to move on to the next question here. So it's a clinical case scenario with the image here. So let's move to reading the statement step by step. A 50 years old patient comes to IOPD for getting a new glass prescription. Okay? So it means patient को कोई ऐसी emergency problem नहीं है. The patient has come just to get a new pair of glasses. On examination, the best corrected vision, BCVA, means that after the glass prescription is given, the best corrected vision is 6 by 6, which is the normal vision. And the anterior segment examination is normal. So there is no problem in cornea, no cataract, anterior segment, no uveitis, anterior segment examination is normal. But the intraocular pressure is 26 millimeter in the right eye and 22 millimeter in the left eye. His fundus examination is as shown in the image. What is the next step in the management? Okay, so let's go to the thing one by one. So this patient beta is 6 by 6 vision, anterior segment normal. Okay, intraocular pressure is 26 in the right eye, 22 in the left eye. Now let's look at the fundus image. So in the fundus image, they have specifically shown as the image of the optic disc. अब जब ऑप्टिक डिस्क का इमेज आता है बेटा, तो सबसे पहले आपको क्या देखना है कि ऑप्टिक डिस्क मार्जिन कैसे हैं, वेसल्स कैसी हैं, हाउ मच इज द कप एंड हाउ इज द रिम. Okay, so margins are well defined, but what is most striking over here? You see, what is most striking over here is the large cup size. Large cup size. So this cup disc is almost, you can say, 0.7, almost 0.7. If you see very carefully here, when I enlarge, there is this bayoneting of the vessels also. Bayoneting of the vessels also. And there is this nasalization of the vessels also because of the increased cupping. So because of the increased cupping, there is bayoneting of the vessels, nasalization of the vessels. So this is the right eye of the patient. Okay, whereas in left eye, if you see, the cup is about 0.4 to 0.5, you can say. So vessels are still not bayoneting because it's not such a large cup. Okay, so do you agree that this patient has glucomatous optic damage? Whenever cupping is more than 0.7 or when the cupping is more than 0.5 and there is a difference of more than 0.2 in the cupping. Okay, so one eye is 0.7, one eye is 0.4 to 0.5. Right eye is showing bayoneting, nasalization, so it is glucomatous optic nerve changes, what you are seeing here. ठीक है, अब क्या ये पेशेंट ग्लूकोमा का पेशेंट है? इज दिस अ पेशेंट ऑफ ग्लूकोमा? So to call a patient or to diagnose a patient as having glaucoma, the diagnosis will be confirmed by combination of three things, beta. High intraocular pressure, optic nerve changes, and the third thing is visual field defect. So the patient should have visual field defect corresponding to the optic nerve changes. Okay, so let's go back to the question. So they are seeing this patient, it means we have found that okay, there are glucomatous optic nerve changes. So what is the next step in the management of this patient? The choice A, there is no need for further examination as the vision is normal. No, that is not right. Because pressure is high, the normal pressure is between 10 to 21 millimeter of mercury. The optic disc is showing glucomatous damage. So even though the vision is normal, you have to do something. Visual field followed by anti-glaucoma drug. Yes, so that will be the one which you will do. Why? Because you will not start the anti-glaucoma drug just on the basis of pressure and optic disc changes, because here pressure is like high 26 or 22, but not as high as where you need to put the drugs immediately. Okay, so first you want to make the diagnosis of glaucoma confirmed by doing visual field, and then you will start the anti-glaucoma drug once you have confirmed the diagnosis. Okay, so the best answer here will be C and not the B and not the C. ठीक है. Review after 6 months for repeat examination, that is also not the appropriate choice here. Okay, so this question, the purpose is to tell you how to identify glaucoma cases and then how to mark an most appropriate choice. Choice C भी गलत नहीं है completely, but the most appropriate choice is do visual field confirm the diagnosis of glaucoma and then start on anti-glaucoma drug. ठीक है, all clear? Fine. Let's go to the next question, bache. Again, a very classical book scenario, but an important topic for your exam. Let's go to the question. Yeah, there is a pressure of 26, Dr. Chaudhary, but sometimes even in the normal eyes, you can get a pressure of 26, though the normal range is 21. But some people who have thicker corneas, just to give you an additional knowledge here, who have thicker cornea, they may have high pressures, 24, 26, and then they may have initial stages of ocular hypertension and not glaucoma. Okay? Okay, a man presents with jaundice and tremor. So again, let's see our keywords here, jaundice and tremor. Eye, yellowish brown ring in the cornea. So all of you have already made the diagnosis. So I'm sure any question related to this topic, you are going to answer is correctly. So what we are talking about here is Wilson's disease. Wilson's disease in which there is hepatic involvement, which is causing jaundice here. There is neurological involvement of the basal ganglia, which is causing tremors here. And the yellowish brown ring, which you see, is your KF ring, Kayser-Fleischer ring, which is due to copper deposition. So in Wilson's disease, which test you think will be helpful here? As all of you are right, serum ceruloplasmin level. Because in Wilson, ceruloplasmins become low and the copper becomes excessive. So that is why there is copper deposition. So it has nothing to do with vitamin A, iron or bilirubin level to confirm the diagnosis. Bilirubin will be high because of the jaundice, but ceruloplasmin is one test which will help us there. Yeah, that's, you are already telling me the gene defect also, so nice. And let's take this opportunity to see how the KF ring looks like. Okay, so you see this brownish ring here, beta. So it can appear as a brownish ring, it can appear as a yellowish brown ring, it can appear as a greenish brown ring. So a ring in the peripheral part of the cornea because of the deposition of copper in desmet is a finding which you will see in Wilson's disease in the eye, KF ring. So besides the KF ring, other thing which you can see is sunflower cataract. Sunflower cataract. Okay? Okay? Perfect. The cup disc ratio, beta, again, it can be normal even up to 0.5 and more than 0.5 also. But then these are the factors which you have to consider. Anything above 0.5 becomes suspicious, but then you have to compare it with the other eye, you have to see the other changes. So more than 0.7 is usually definitive of glaucoma. Okay? So if you find it's more than 0.5, discrepancy is more than 0.2, go for glaucoma. Okay? Okay. Again, beta, a very classical scenario. All of you are already telling me the right answer, most of you. And but let's go through the question so that we know what we need to look for in this kind of question. A young man with a myopia of -7 diopter was hit on the left eye with a cricket ball. So risk factor here is beta high myopia, trauma. Cricket ball lag gayi bechare ko. 2 days later, he developed flashes of the light. Very important symptom. Photopsia, flashes of light. And then a curtain-like shadow in field of vision. Again, a very, very important key symptom. So these two things happening together, beta, or this clinical case scenario, okay? Trauma in a myopic patient who is at risk of developing retinal tears or retinal breaks has flashes of light. There can be increased floaters also, and a curtain like shadow. So when there is this curtain like shadow in the field of vision, make sure that you mark your answer as rhigmatogenous retinal detachment. ठीक है जी. Tractional retinal detachment will not cause curtain like shadow. It's usually slowly progressive. It's usually slowly progressive. Most common causes diabetic advanced PDR or proliferative diabetic retinopathy. There are other causes also. It can occur in trauma also, but that will be not because of retinal break. It will be because of the trauma related fibrosis occurring in the retina. Okay. Vosseous ring is just a pigment ring on the lens capsule. It does not causes any decreased vision. Okay. So lattice degeneration can be present, but lattice degeneration in itself is not going to cause the curtain like shadow unless there is a retinal hole formation leading to retinal detachment. ठीक है जी. So this is how the curtain like shadow, why the curtain like shadow occurs, because whenever beta, again have a look at this fundus image also to identify how the rhigmatogenous retinal detachment looks like or RRD looks like. Because of the subretinal fluid under the retina becomes elevated, ballooned up. Okay, so I use the word ballooned up, ऐसे balloon की तरह lift हो गया है, and because of that elevated retina which is now covering the field of vision. So this ballooned up retina covers the field of visions like for a curtain like shadow. ठीक है जी. Yes, there can be a horseshoe tear. Obviously, the rhigmatogenous retinal detachment has to be because of a retinal break. Now, mostly any acute trauma leads to horseshoe retinal tear. This particular fundus image is not showing you that because it's not showing you very peripheral part of the retina. But if it is a tear, it will appear like this beta. The tear, through the tear, you can see the red choroid there. So there can be a horseshoe tear, which is the most risky type or most dangerous type of the retinal break, or there can be just retinal hole also developing. Okay, so these are the things which will be there whenever there is trauma in a high myopic patient. These two are important risk factors for development of rhigmatogenous retinal detachment. Yeah. Okay. Yeah, Schaeffer sign can be there and all that stuff you already know. Okay. Moving on to the next question, bache. Moving on to the next question. Let's read the question statement. A patient with hyperthyroidism is referred to eye OPD due to staring appearance and bulging of the eyes. All of the following can likely be seen in this patient except. So here actually beta, the most important thing I want you to make sure is don't leave the word except. ठीक है. एग्जाम में क्या होता है, ऐसे क्वेश्चंस जो इजी होते हैं, ऐसे क्वेश्चंस जिनमें हमें वी आर श्योर ऑफ द आंसर, हम उनको ओवर क्विकली मार्क करने की कोशिश करते हैं. वी ट्राई टू बी लेट्स सेव द टाइम ऑन दिस काइंड ऑफ क्वेश्चन, बट these kind of questions, they also lead to silly mistakes when we miss something like except. Okay, so I'm sure all of you know the answer of this question, but you can give an extra second to be attentive during the exam before marking your answer. So everything is written in front of you. Patient has hyperthyroidism, staring appearance and bulging of the eyes. So patient is having thyroid eye disease, or what we call as thyroid ophthalmopathy. So in thyroid ophthalmopathy, there is a spectrum of the signs and symptoms you can see. Oh, my ophthalmopathy spellings are a bit wrong here. Ophthalmopathy. So you see a proptosis in thyroid? Yes. The proptosis in thyroid is also called as eggs ophthalmos. Okay, so sometimes they use the term eggs ophthalmos for the proptosis or protrusion of the eyes which you see in thyroid ophthalmopathy. Okay, lid retraction, which is the first sign to appear in thyroid eye disease, also called as Dalrymple sign. then you can have this staring appearance as if the patient is constantly staring at you. That's called Cocker sign. Decreased vision, yes, decreased vision, let me just correct here. So decreased vision can occur because of the optic nerve compression. So if the optic nerve gets compressed because of the excessive tissue in the orbit, that can cause decreased vision. Ptosis is not seen in thyroid eye disease. Okay, so there can be restrictive myopathy involving the extraocular muscles, but there is no involvement of the LPS to cause ptosis. So this is the right answer here, as you told me, and this is how, a bit more related to, if you get a figure like this is how exactly your patient of thyroid eye disease will look like. Okay, so you notice here both eyes are showing proptosis, so it's a case of bilateral proptosis. So it's a good time to remember that thyroid eye disease is the most common cause of unilateral as well as bilateral proptosis in adults. Okay, so you see here lid retraction, Dalrymple sign, you see the staring appearance of the eyes. So this is your thyroid eye disease. And can you tell me the name of the instrument here which you are seeing here, beta? Yeah, infrequent blinking, Stellwerk sign. So this instrument is called eggs ophthalmometer. Okay, so what they are doing is here they are measuring the proptosis. Okay, so if a question related to this comes, now you know this as well. This is Hertel's eggs ophthalmometer. Eggs ophthalmometer is an instrument which is used to measure proptosis. Eggs ophthalmometer to measure proptosis. Proptosis measurement. Okay, my dear friends, all good here? Perfect. Time to move on to the next question here. A patient, another clinical case scenario, friends, a patient with history of rheumatoid arthritis. So again, let's go one by one. Rheumatoid arthritis. Small nodular lesion in the scleral area. Rheumatoid arthritis, a nodular lesion in the scleral area. Okay, the lesion is recurrent. The lesion is recurrent and reappears after 2 to 3 months. So it gets resolved by eye drops. So it means it's responsive to the treatment, but then it is recurrent. Okay, then it is recurrent. What is the likely diagnosis in this case? Now coming to the choices here, beta. Is it a nodular scleritis, nodular episcleritis, scleromalacia perforans, or pterygium? Okay, so let's rule out one by one. Pterygium. It's not pterygium because pterygium is not a nodular lesion. It will not get resolved by the eye drops. If you have to do, it has to be the surgical excision with conjunctival autograft, we know. So pterygium is ruled out here. Scleromalacia perforans. So that can be seen in a patient of rheumatoid arthritis, but again, scleromalacia perforans is not causing a nodular raised lesion. It rather causes scleral thinning. Scleral thinning. So, and it is more commonly seen in long-standing rheumatoid arthritis. Okay, so as you know, it is seen in long-standing rheumatoid arthritis. Now, is it a nodular scleritis? Now, I have always told in the class, difference between nodular scleritis and episcleritis. But episcleritis is a superficial part. Episclera is a superficial part of the sclera. Okay, so when the inflammation is involving only the superficial part, we call it as episcleritis. Whereas when it is deep, it is called scleritis. Now, superficial will be milder. It will be responsive to the eye drops. Okay, deeper inflammations will be more severe. They will be more painful. They will not go away with the drops. They will require systemic treatment depending upon the cause, whether they require systemic steroids or immunosuppressants. Okay, so obviously here the choice will be nodular episcleritis, and it is a typical presentation. The episcleritis is a recurrent in nature, especially in the setting of rheumatoid arthritis. You give anti-inflammatory agents like non-steroidal anti-inflammatory agents, it resolves, but then it recurs again. Okay? So it is episodic, as you tell, and this is how it looks like. Okay? So episcleritis, as you know, can be diffuse or it can be nodular. Here we are talking about a nodular lesion, which is involving the superficial area, episclera only. If it is scleral, it will be deep red. It will be deep red, and in the symptoms, it will be very symptomatic, very painful. Okay? Another question sometimes which they can ask you, though they have not done for the FMG exam as till now, but I will definitely want to share that with you, that the congestion which you see in episcleritis. So if you put phenylephrine eye drop in this eye, so phenylephrine is the decongestant. So these eye drops, they will, if you put in episcleritis, so in episcleritis, that will cause resolution of the congestion. Okay, so that will cause temporary resolution of the congestion or redness, because it's only superficial vessels which are congested here. Okay, so you put a drop, a decongestant drop like phenylephrine, the redness will disappear. Yeah, even the milder dose, 2.5%. Whereas when it is a deep inflammation like scleritis, their deep vessels are congested. So phenylephrine is not going to have the decongestion of those deep vessels. Okay? So in case we get a question related to that, so scenario of episcleritis, scleritis, scleromalacia perforans, we know all. Okay, bache, moving to another question here, which sometimes causes confusion to you. So let's do this so that we can kind of like, clear our doubt also. So the question is, a young girl who is a soft contact lens user, a young girl who is a soft contact lens user comes with redness, pain and decreased vision. Comes with redness, pain and decreased vision. Okay. So again, let's go to all the points. Soft contact lens user. Painful decrease in vision. On examination, the following findings are seen. What is the most likely diagnosis? What is the most likely diagnosis? So risk factor is soft contact lens user. Okay. There is redness, there is pain, there is decreased vision, and this is what you see in the eye, bache. Okay, so what do you see in the eye here? You are seeing lot of redness, congestion. Okay, you are seeing that there is an infiltrate and ulcer on the cornea. Okay, so infiltrate and ulcer on the cornea in this area, and if you see very carefully, there is even thinning in this area, beta. Okay, so this is a corneal ulcer. This is a corneal ulcer, and it is a bacterial corneal ulcer. It is the bacterial corneal ulcer. Wet infiltrates, well defined margins, area of thinning which can lead to perforation. Okay, so what do you think it is? Yes, you are very right. It's a pseudomonas bacterial corneal ulcer. So the diagnosis here is bacterial corneal ulcer due to pseudomonas. Now, why it is not a fungal corneal ulcer? Because fungal ulcer, you know the typical appearance, dry raised infiltrate, satellite lesions, ill-defined margins, big hypopyon, and then contact lens use is not a risk factor for fungal ulcer. It is trauma, vegetative trauma. Okay. Why it is not acanthamoeba keratitis? Acanthamoeba, if it would have been a ring-shaped ulcer, and that will be very, very painful due to keratoneuritis. Okay. Why it is not giant papillary conjunctivitis? Because in giant papillary conjunctivitis, there will be no decrease in vision and cornea will be clear. There will be no lesion in the cornea. So why this question causes a confusion. Sometimes the confusion occurs, bache. Sometimes we say, oh, contact lens user, it has to be acanthamoeba. So pseudomonas is the most common cause of infective corneal ulcer in contact lens users, beta. Pseudomonas is the most common cause. Then here, the clinical appearance of the ulcer is not like ring ulcer which you see in acanthamoeba. It is the bacterial ulcer. Okay. Why it is not giant papillary? Because if it is giant papillary, it will cause only conjunctivitis like symptoms and signs. There will be papillae, there will be redness, there will be itching, but there will be mild discomfort, no pain. No pain, you don't get pain due to allergic conjunctivitis. It can be discomfort, and there will be no decreased vision. Even if you don't get a picture, but if there is no decreased vision, only then it will be giant papillary conjunctivitis. If it is decreased vision, then it will be a corneal ulcer. Okay, so I am hope very clear, because I get so many doubts related to this kind of clinical scenario. Okay, yes, so ulcers, they tend to develop when the person has poor hygienic habits related to contact lens use, poor cleaning of the lenses, shearing of the lenses, using tap water for the lenses, etc., etc. ठीक है जी, right? Okay, moving on to the next question, बच्चे. What will be the first step in management of a 5-year-old girl brought by her mother with the following findings? Okay, so the age of the girl is around 5 years, and these are the findings which you see in the eye. These are the findings which you see in the eye. Okay, so what do you see in the eye here, beta? This is the right eye. This is the left eye. This is the right eye, and the right eye is showing convergent squint here. The right eye is showing esotropia or convergent squint here. Okay? And the left eye is appearing to be central. Right? Convergent squint, why the third nerve will be involved in convergent squint? Third nerve does not supply lateral rectus. So this is not exo, beta. Which eye is showing exo? See carefully. The right eye is showing esotropia, convergent squint. I hope every one of you is clear. Okay. Now, what will be if a child like this comes to you? What will be the most appropriate first step in the management of this case? The first step in the management of this case, let's go by the choices. Do you do occlusion therapy, or refraction under cycloplegia, or squint surgery, or orthoptic exercises? So the first step for a squint in a child is to do refraction under cycloplegia, beta. Okay, so the B is the right answer. You will do refraction using atropine. Atropine is the cycloplegic of the choice when there is squint in the eye, because first of all you want to know what is the refractive error. If there is refractive error, you will be correcting that refractive error, and the type of the esotropias which are accommodative. Okay, so the type of the esotropias which are accommodative esotropia, they many times can be corrected by giving the glasses itself, beta. Okay, so the same child here was having right eye esotropia. So once you do the refraction under cycloplegia and give the corrective glasses to the child, see, the eye has become central now. No tropia here. It has become ortho. So that will be the first step. That will be the first step. Yes, most of the time these people, they have hypermetropic refractive error, and they can be corrected by giving the hypermetropic glasses. Okay, if then the next things, because sometimes this child may already have amblyopia because of, maybe the child has the squint since birth or since last 2 years and it was not treated, or the refractive error was not treated. If the child shows amblyopia, then after the correction, after giving the glasses, you will do occlusion therapy. Okay, you can prescribe orthoptic exercises to the child in addition to the glasses. And if the squint is not corrected fully by glasses, after certain age, mostly after the age of 8 or 9 years, then you might require squint surgery. Okay, but the first step will be refraction under cycloplegia. Okay, so I hope I'm clear here. Fine, bache? Good. Moving to the next question, beta. Moving to the next question. A 2 months old child is brought by the parents with leukocoria in the right eye and a diagnosis of congenital cataract is made. So again, look at all the things carefully. What is the age of the child? 2 months old. Leukocoria. Now leukocoria, is it a retinoblastoma? Is it something else? Because there is whole differential of leukocoria. Fortunately, here they have already told you what is the diagnosis. Congenital cataract. So congenital cataract in a 2-month-old child. All of the following are true in the management of this case except, again bache, so what will not be ideal for managing congenital cataract in a 2-month-old child? Let's go choice by choice. Plan cataract surgery as early as possible. That is correct because there is cataract only in one eye. Only in one eye, beta. Okay? So unilateral cataracts, unilateral congenital cataracts, they are at high amblyopia risk. So you will try to do cataract surgery as early as possible. Lens aspiration with primary posterior capsulotomy with interior vitrectomy is the surgery of choice. Yes, for congenital cataracts, you do a primary posterior capsulotomy because the risk of posterior capsular opacification is very high in children, and less than 2 years of the age, we also combine it with anterior vitrectomy. Okay. Intraocular lens power should be undercorrected. That is true because these children, as their eyeball will grow, they will undergo myopic shift. So this myopic shift is going to affect their lens power, bache. So you will undercorrect. You will not give the full power as calculated with the formula. Okay. Wait till 2 years of the age for optimal eyeball growth. Now this is absolutely wrong because as I already told you, unilateral cataracts, congenital cataracts are at very high amblyopia risk. If the light is not going inside the retina to stimulate it, because of the cataract, there will be suppression of the vision and this child will develop sensory deprivation amblyopia. Even bilateral cataracts will cause that, but unilateral, because one eye is normal, the eye which is weak, that is a rule of the nature. Whatever is weak will be suppressed further. So unilateral cataracts, they have to be managed as early as possible. Okay, ji? Yes, do not wait. That's the right way to say it. Okay, bache, coming to the last question of this session. Again, a very easy one, but an important one. So, which of the following drugs can be safely given in a patient with intraocular pressure after cataract surgery? So, patient underwent cataract surgery. So, sometimes, in the post-op period, the patient can develop high intraocular pressure. So, which of the drug can be given safely in such a scenario? The choices are travoprost, pilocarpine, brimonidine, latanoprost. Okay. A bit of the thing to see over here, what is the purpose of giving this question is, now after cataract surgery, there is some inflammation in the eye. Okay, there is some inflammation in the eye. And then another risk factor which can occur in the patient of cataract surgery is risk of cystoid macular edema. ठीक है? So post cataract surgery, what are the things you are keeping in mind? ठीक है? What are the things you are keeping in mind? Patient has post-op inflammation. Because usually the pressures, they are high when there are post-op inflammation, and the patient can have risk of another complication of cataract surgery, which is cystoid macular edema, that can help develop. Okay, so because of this, you have to avoid the drugs. Which can cause this. So which are the drugs which are to be avoided if there is risk of cystoid macular edema or in the presence of inflammation? The two drugs which you avoid is beta to be avoided are prostaglandin analogs, ठीक है, and pilocarpine. Because if you remember, these are the drugs which increase the inflammation, and these are the drugs which also increase the risk of cystoid macular edema. So these should not be given, ideally. Other than that, you can give any of the drugs. So coming to the choices here, travoprost is the prostaglandin analog. So anything ending with prost is a prostaglandin analog. So you will not give prostaglandin. Pilocarpine, again, I just told you it's contraindicated. Okay. Brimonidine, you can give. Brimonidine does not have any contraindication related to inflammation or cystoid macular edema. So you can safely give brimonidine for the pressure control. In this case, latanoprost, again a prostaglandin patient analog, so you will not give. Fine. So in this scenario, if there is a pressure to be controlled in a patient post cataract surgery, avoid prostaglandin analogs and pilocarpine. Okay. Now for all the anti-glaucoma drugs, beta, let me just put in a word. Please do remember the contraindication of the anti-glaucoma drugs, their mechanism of action, and the important side effects. So as such, prostaglandin analogs is the first line drug to start a medical therapy of glaucoma unless there is a contraindication. The contraindications are these two only for prostaglandin: uveitis or cystoid macular edema. ठीक है जी, right? Timolol or beta blocker, you will not be giving them in asthma, you will not be giving them in patients with heart block or COPD. Brimonidine you will not give to children because of the sleep apnea. Brimonidine is safe for the patients who are having pregnancy and develop high pressure during pregnancy. So these are the few things which and you should have a quick recap of anti-glaucoma drugs before your exam. Okay, so that ends my session over here for today, and I hope that has been a useful session for you. Again, if you were not able to give the right answer to any question, do not lose heart, beta. The purpose of this session is to revise. The purpose of this session is to make you aware that these are the important topics for your exam. The purpose of this session is to make sure that we committed the mistake now. कोई बात नहीं, गलती हो गई, गलत आंसर बोल दिया, but now we have corrected ourselves and we will not do the same mistake in the exam. Okay? So I just got this quote from the Google, and this is, I must give credit to Mr. Abhishek Tripathi who wrote this quote. The quote is, रुकना नहीं है, थकना नहीं है, बस बढ़ते चले जाना है. Okay? So this is the time now. रुकना नहीं है, थकना नहीं है, बस बढ़ते चले जाना है. रास्ते मंजिल के कठिन है तो क्या हुआ? It's a very difficult path, beta. We all have gone through this path in some way or another. ठीक है, आज से 25-30 साल पहले हमने भी यही पाथ लिया होगा. सो रास्ते मंजिल के कठिन है तो क्या हुआ, खुद को भी तो आजमाना है. सो इफ यू सी मी हियर, you can see yourself at this position in the future. So all the very best from me, from all of the Miss team. We are always there with you. Keep a positive spirit. You will and you can and you will definitely do. Okay, so I'm waiting for the messages from you for that. Yes, I did it. All the very best, my friends. Keep a positive spirit. ऊपर नीचे होता रहेगा, बस खुद को आजमाना है उस दिन के लिए, रुकना नहीं है, थकना नहीं है. Thank you so much for such an interactive session. God bless you, beta. Keep studying hard. Keep taking care of yourself. And whenever you feel down, just look at the mirror and smile at yourself. Thank you so much. Take care. Yes, the PDF will be uploaded very soon. I'm going to share the PDF with the team and they will be uploading it. Okay. Thank you, beta. I'll take your leave for now. Take care.